Good morning and good afternoon, everybody. My name is Katri Kontio from Regional Office of Pan American Health Organization. I'm Digital Health Advisor, and I'm opening today's webinar, and I'm pleasure to welcome you to this part of the community practice CRVS Information System of Health webinar series. This is a multilingual webinar and simultaneous interpretation is available. The main presentation will be in Spanish. And today's discussion focuses on the implementation of ICD-11 in real clinical environment, an area that is becoming increasingly important as the countries move from planning to practice. And I would like to extend our appreciation to colleagues from Chile, in particular Dr. Jorge Pacheco, Head of the Department of the Health Statistics and Information Days, Ministry of Health of Chile, and Doctora Paulina Vera from Hospital San Juan de Dios, Chile, for their leadership and for sharing their experience within the region. And Chile's experience is especially valuable because it looks how the ICD works in daily clinical workflows, including challenges related to usability, integration with the systems, and the use of more detailed coding such as post-coordination. We also recognize the broader collaboration supporting this work within the country and across the region. And it's now my pleasure to hand over to Dr. Sergio Guiñez, Head of the Biomedical Informatics Laboratory at the University of Talca, who will present the Chilean experience. Sergio, the floor is yours. Thank you.
Thank you, Catherine, for introducing me, and thank you for everyone for connecting in this webinar. La presentación, agradeciendo la traducción simultánea, la haré en español.
Utilizing the simultaneous interpretation, I'm going to make my presentation in Spanish to be more fluid at it, mostly to focus on the audience that speaks Spanish and that will be connected with us. Today's presentation focuses mostly on the implementation pilot of ICD-11 and the mobility model in Chile in 2025, coordinated with PAHO and the DIEIS from the Ministry of Health from Chile and the Service of Healthcare from Mali, together with the San Juan de Dios Hospital Greco, where I belong, which is the Talca University in Chile. Among the most important authors of this work, we have Paulina Vera, the clinical leader of the team, and the one that came up with the original idea here in Mali. Paulina Leighton, De La Piedra, who are the team of coders, Jaime Gonzalez, and IT engineer working with us, and Jorge Pacheco, who is a leader in the team in the IEIS. And here is my contact information in case you have any questions or want to talk about these implementations and convey what we've done from the university. This is the lab I work with. Very interesting, and for a position thing of why I work with and where I work with, which is the Talca University, which is the Simulation and Biomedical Informatics Lab. Moving on to tell you about the details of ICD-11's mobility in Chile, we mainly start by the ICD-11 itself, which is the current international standard that they have to record and analyze mobility and mortality. So this endured an evolution from the very well-known ICD-10, which was the international classification for diseases. We are now in the 11th version, that it has a whole lot of qualities and features that differ from the one before. One is that it is completely designed in digital. So it's already been pre-designed for digital settings, which mostly facilitates its adoption, integration, interoperability, which is the most important part, with electronic clinical records. From the syntactic and semantic standpoint,
con otro tipo de clasificaciones, lo podemos incorporar con
For other
estándares
type of
que
classifications,
utilizan más
we're
bien
going to incorporate them
para
from
poder
standards that are
hacer
mostly syntactic to be
esa
able
PAHO de
to
información entre
transfer
la API, que es
information
la
between the
ICD-11, que ya les voy a
API
comentar
from
y les voy a
ICD-11, which
ahondar
I'll be delving
qué
into
enfoca la API.
to tell you what that
Registros
API
clínicos
focuses on.
electrónicos es
So
un
between
sistema
electronic
gubernamental
records,
cualquier sistema
the
de información en salud en Chile.
local systems, and any healthcare systems in general.
Actualmente nosotros estamos desde el punto de
Currently,
vista regional,
we are
comenzamos
from
con la
the regional
implementación del
standpoint,
piloto.
starting with the
El
implementation of the
piloto
pilot,
tuvimos la fortuna de ser
where we
escogidos
were
para liderar
lucky
este
enough to have
trabajo
been
que
chosen to lead this work.
lo comenzamos desde regiones,
And we
desde
started
la
doing
región
it
del Maule
from
en
the
Chile,
regions from Maule
en un
in
hospital
Chile,
de alta
in a
complejidad que es el
high
Hospital San Juan
complexity
de Dios de
hospital,
Curicó,
the San Juan de
donde
Dios de Curico Hospital.
lo que hicimos principalmente fue
And what we did there
enfocar,
mostly
y le voy a contar en
was
detalle,
to
enfocar
focus
la
on, and
API
I'll give you
ya
detail on
como lo
that,
que es
to
el
focus that
entorno
API
tecnológico a
and to look at the whole
disposición
technological
de los
setting
egresos
to
hospitalarios
put it
de la región.
available for the hospital discharges at that particular hospital.
¿Cuáles son las principales características
The most important
que posee el
characteristics
ICD-11 que la
the
distinguen de su
ICD-11
antecesora CRVS?
has that
Actualmente que es
are
digitalmente nativa.
different from the
¿Ya?
one
Esa
before.
fue
Basically, is that
desarrollada
is all
para
of it
entornos
digital. It was
digitales. O sea,
developed for digital
tenemos dentro
environments.
del
So
sitio
we have
de
within
el
the
E11,
website
que
of
después lo vamos a ver
ICD-11.
a modo de
We're going to
posicionamiento,
look at
pero
it
no
from the
nos
very
vamos a adentrar
positioning.
en detalle dentro del
We're not going to
sitio
go into
por el
further
honor al
detail
tiempo. Sin
because of
embargo, para que
time,
puedan conocer un poco la
but so
navegabilidad
that
del
you can
sitio, es
see a
bastante
little bit of the
intuitivo.
navigability, it's quite an
Es bastante
intuitive
intuitivo desde el punto de
website
vista de las
from the
herramientas
standpoint
que
of
posee, tanto
the
los
tools
browsers como
that browsers
el
have, as
material que
well
viene
as
desde el punto
the
de vista
material
formativo, desde el punto de
that
vista de la
comes from the
aplicación, las
very
guías
training part
prácticas,
of
cómo se
the
aplica,
application, the
y
practical
además
guides.
viene con todo
And
lo
it
que es el
also
entorno
has to do
tecnológico o
with
la API que
everything
nos
that has
permite,
to do with
ya
the
cuando hablo de la
technological
API, hablo
setting. And
de
when I
la
talk about the
interfaz
API, I'm talking about the
de
interface
conectividad entre
and the
el
connectivity
browser que nosotros lo podemos
between
bajar
the
y lo podemos
browser
encapsular dentro de un
that we
token,
can bring down
que
and
es
contain it
el
within a
concepto
token,
técnico que se utiliza para
which is
encapsular
the concept
una aplicación y esa aplicación funcione de cualquier forma
for the
en un
capturing of
entorno
this
local o
application
en
that
un
it
entorno,
happens in any possible
podríamos
way
decir, en la nube o desde
in
la
a
cloud.
local setting
Nosotros
or in
podemos
the cloud.
tener esa opción, como fue
We can have
digitalmente
that option,
desarrollada, nosotros
just
podemos
as
bajar
digitally
completamente
developed.
la API
We
y
can bring
posteriormente
the
obviamente
API
actualizándola
completely
y
and keep on
tenerla dentro de
outdating it
nuestros
so
equipos.
that we
Más
can have it within
poderosamente
our
dentro de nuestros
equipments,
equipos de
within our
SAP.
computers. We can have them within
Para
our
ver
local
cómo se conecta o
equipments to
almohadas.
play around
¿Ya?
with it to see how it
Lo que
connects.
se
We can
denomina
do that.
Foundation Component
What we call the foundation
es
component
un
here
componente bastante
is
importante dentro de las
an
características
important,
descriptivas
very important component
de
within the
la
characteristics
amplia
of the
proliferación del
ICD-11
número
from the
del número de
expansion
términos, de conceptos, de
of the number
lenguajes,
of
de
terms
lenguajes,
and concepts which are called
es
entities,
bastante en comparación con su antecesora
that it
CRVS,
is
¿ya?
quite
Lo que nos permite
a lot
generar en
different to
general
the one to the version before.
múltiples vistas clasificatorias y
With
podemos tener una
multiple classification
especificidad
views, we can
bastante
have a specificity
certera en
that is
cuanto al
quite
diagnóstico que nosotros
very
tenemos que definir.
accurate
¿Ya?
in terms of the diagnosis we want to reach.
Incorpora un concepto que es
It
la
incorporates a concept
post-coordinación. ¿Ya?
that
La
is a
post-coordinación es un concepto
post-coordination,
que
which is a
enriquece mucho el
concept that
diagnóstico
very
primario
much enriches the primary
con
diagnosis
nuevos diagnósticos que se
with
pueden
new diagnosis
incluir
that
en
could
el
be
diagnóstico. Y
included
después lo vamos a ver
posteriorly in
como
the
ejemplo
diagnosis
cómo
itself.
funciona esta
As an
post-coordinación.
example
Podemos incluir
of this
otros
post-coordination,
diagnósticos o podemos
we can include
incluir
other
lateralidad,
diagnoses,
y
or we
podemos
could
incluir
include
anatomía,
lateralities, we
podemos
can include
enriquecer el
anatomies, we
diagnóstico
could
primario
enrich
con
the
otros
primary
códigos
diagnosis
que
with so many other
posteriormente
codes
generan
that
codificación.
help
¿Ya?
the
La
coding
actualización es
further.
continua, o sea, la OMS
The
está
continuous
en un modelo de
update.
gobernanza abierto que
WHO
permite al
has
usuario
an open
generar
governance
y ir
model that
mutando
allows the
en
user
estos pilotos
to look at the changes and work
ayudamos
with them.
mucho
And
a eso,
these pilots help a
porque los
lot to
pilotos lo
it
hacemos directamente con
because a
los equipos
pilot is
clínicos.
something that we do
Los equipos
directly with the
clínicos
clinical teams.
están haciendo la
These
dirección
clinical teams
hospitalaria.
that are
Entonces,
working
ellos nos
constantly
van
with the
diciendo, y ese
admission, the
es
hospital admission
un modo de
itself.
retroalimentación para la
And so this is
OMS
a
y para
feedback
la OMS.
mechanism for
Y
PAHO
dentro de
and for
eso
WHO.
vamos
And so with that in
retroalimentando
mind, we're
también el
constantly
desarrollo
feeding back
de
the development,
la misma terminología.
of the
¿Ya?
very
Viene
terminology.
nativamente con multilinguaje, está disponible
It
en
natively
idioma
comes as
español en este caso
multilingual, so it's going to include the languages that we use.
adopta rápidamente, uno no tiene que hacer una configuración
So
extra.
you don't have
Lo
to
que
work
uno
with
debe
an
hacer
extra
simplemente es
setting
configurar
or
el idioma
configuration, because the first thing
ya
that you usually
viene
had to do was the
adaptado
configuration of the
a
languages.
la realidad regional. ¿Ya?
In this case, it's already
Además,
adapted
viene
to the
con
regional
interoperabilidad
reality.
semántica con otros
It
estándares
already comes
ya
as well with
así,
semantics
bueno,
interoperability,
con una
bringing
gama de
then the
estándares tanto
compatibility with the variety
semánticos
of
como
standards that are going
sintácticos,
to be
y
semantic,
esto se agradece desde
syntactic,
el punto de vista de la
and
interoperabilidad,
all of this is very
porque
much
en general la interoperabilidad
something
en
that we
Chile
appreciate in
tiene
terms of
múltiples
interoperability, because
estándares donde
the
nosotros podemos
interoperability itself has
explorar.
many standards that we
Tenemos estándares
have the
semánticos
possibility
y
to explore. And so we have
sintácticos
semantic and
al ser
syntactic.
un API abierta.
And by
Posee esa
being an open
característica
API,
la
it
interoperabilidad
features
semántica con
that
otros sistemas.
specific
¿Ya?
of the semantic
Este es el
interoperability
sitio.
with other
El
standards.
sitio en
This is the
general
actual site.
no voy a adentrarme
I'm not going to
en
now delve
detalles
too
dentro del
much
sitio,
into
pero
further
lo
details
pueden, lo
about
pueden
the
ir al
website
navegador.
itself, but if you
Voy a
can
dejar
go to your
aquí al
browser,
lado
you'll be able to see
mi
it. I'm going to
navegador que
leave
se
that
explica
there so that you can see it.
bueno, el multilingüismo incorporado,
As you can
tiene
see, it has
obviamente
incorporated
el uso de la ICD-11,
multilingualism. It
tiene
has
información
the
para que ustedes
tools of
puedan
how to use
incorporar,
ICD-11,
incluso pueden
further
entrar el
information.
navegador,
Like
el
here, we
navegador de
could go
términos,
to the browser
donde
of
es un
terms
case
itself.
sensitive, donde principalmente
It's
ustedes
going to
pueden ir
be
incorporando
capital sensitive,
estos
so
datos
you'll
para que puedan
incorporate
rápidamente
the terms
encontrar
and then
la
quickly
codificación
find
y
the
posteriormente lo que
codes
les
that
comentaba,
belong
la
to it, and then
coordinación hacia abajo. ¿Ya?
what I told you
Ustedes hagan
earlier, the
cuenta,
post
no
coordination right
vamos
below.
a
Because of time, though,
ahondar en detalles del
we're not
sitio,
going to go
pero
into further detail about the website.
tienen el código QR
But as
donde
you
ustedes
see,
también
you
lo pueden
have
ver
the
o
QR
pueden
code
hacer
where you'll be able
esto y
to
lo
look it up.
googlean rápidamente
And
y
in
van a
fact, if
poder.
you Google it
¿Ya?
up, you'll
Lo
see
importante
it.
acá también y la gran novedad es
What's also
que
important here,
al ser
as the
diseñado
great
nativamente
novelty, is that
digital,
by
tenemos
being
un espacio
designed
para la API.
fully
¿Ya?
digital,
Dentro del
we have a
website
space for the
podemos
API. And in
ver
it,
cómo se usa la API, la
we're able to
documentación
learn how is
técnica,
it going to be
tanto para
used
diferentes sistemas
and the
operativos,
technical
para
approach
Windows, para
for
sistemas Linux,
several operative
cómo
systems,
podemos ir
Linux, Windows, etc.,
interiorizándonos más de la
to be
información
able
técnica.
to
Tan
learn
sencillo
further
como
about the
ingresar,
technical information
ustedes
is quite
pueden ingresar y
easy
lo
to
pueden
use.
ver en detalle.
So you can enter and look it up in
Ahí está,
further
si lo
detail.
quieren pistolear
You can
el
see
QR y está
the history
la
there.
información
Here's the QR
de la
code
web.
and the information
Lo que les
of the
mostraba un
URL.
poco, esto
But I was
algunos
telling you a
screenshots
little bit, and these are some of the
de la demostración de
screenshots
Sensitive
as of
en el
what we
browser
did in the
bastante
exercise.
elegante.
And
Y
as
este
I told you, the
browser
browser is quite
tiene las
friendly.
mismas
This is a browser
características
that
en la
shows the
API
same
cuando ustedes lo
features as
bajan.
the API
Entonces, ustedes lo pueden
as when you
trabajar de
download
forma
it. So you
online
can
para poder
work in a
interiorizarse
live
cómo se
manner
usan los
to
que
be
ya han
able to
instalado
learn how
y
to
cómo se
find the
puede
different
ver mayor
entities, which are the
detalle
terms,
y cómo
how to look into
puede
further
existir
detail,
una postcoordinación posterior
how can there
de este
be
mismo
a
término que se
post-coordination of
dio
that term,
entidad con otros diagnósticos. Es bastante
how to
intuitivo
find other
de usar.
diagnoses. It's quite
Esto
intuitive to use.
yo podría decir
So
que es una de
I
las
could
mayores
tell
fortalezas
you
que tiene
that one of
Biomedical.
the
Es
most
muy
important
intuitivo,
strengths
la
that the
idea es
ICD-11
poder
has is that it's
trabajar
very
en
intuitive.
esta
It's
API.
quite
Eso requiere mayor
cross-sectional. It can use
información.
information from
¿Ya?
any places,
Entonces,
and so it
pasando a
doesn't
hablando
require a whole
del
lot of more
piloto,
training.
el objetivo
Now,
que
going further
pusimos durante el año
into
pasado
the
fue
pilot itself,
evaluar la
our
operabilidad
objective
técnica
last
y
year was to
concurrencia
be able to
diagnóstica, la idea
assess
era
the
levantar
technical
todo esto dentro del
viability
website,
with all
hacerlo
the
realidad
diagnostic
a modo de piloto
study and run it as
y
a
evaluarlo
pilot,
principalmente
and to
en un
evaluate it
hospital de la región del
at an
Maule.
actual
¿Ya?
hospital in the region of
Evaluar la
Maule.
concurrencia diagnóstica en egreso
So
hospitalario.
we had to be that it
Dentro de los
had a
objetivos
good
específicos
diagnosis
que
match within
trazaron,
that hospital. And
primero
among the
era
specific
implementar
objectives, the
y
first thing
testear
was to
todo lo que
implement
era la API
and
REST.
test everything that
La
had
API
to do
REST,
with the
desde el punto de vista
ICD-11
técnico,
API REST,
REST es
which
un
from
estilo
the technical
arquitectónico
standpoint is the
principalmente
architectonical
que
standpoint of REST
permite
that would
este tipo
allow
de desarrollos
for
tecnológicos que
this
sean
type of
abiertos,
technological developments to be
donde
open.
operaciones como leer,
So in
cortar,
operations such as reading,
borrar,
updating,
y
deleting,
copiar, o
or
sea, que es
creating,
la cifra CRUD de la
which is
OPS,
which is
son
going to be
fáciles de
like the
hacer.
raw form
Entonces,
of it, will be
¿ya?
easy to do.
Y es así como los
And
principales
that's how the
arquitecturas de la web
most
hoy en
important
día
architectures
están
of the
basadas
website today
en
are
la
based
arquitectura
on
REST.
the REST
Entonces, la
architecture.
idea era
So
bajar
then the
esta
idea
API
was to bring these
que provee a
API
través del
down,
sitio de la
down
OMS
the WHO website with a clinical line, not only to play around with it, but to actually create a pilot with hospital discharges. And so what we did with that was to develop an additional platform, a platform that we could help increase, and we called it DAISY ICD-11 with data analysis. Good for us to train the clinical professionals on what they should use. The API with the ICD-11, simulating the Chilean settings. Another specific objective we had in mind was to be able to compare the matching once having installed the ICD-11 API and its performance to make it interoperable between the medical settings. It needed to be interoperable. It could be easily done and friendly to do between the ICD-11 API and the medical electronic medical records as well that are used at the hospital. And once done, the idea was for the clinicians to be able to code directly within that hospital discharge form, which in this case is digital, which is part of that electronic record, in fact. And comparing, once having all of that, what was the matching between what the physician had entered, who was the first user using this specific platform we are promoting, a coder at the hospital who will work within the biostatistics department at that hospital, and they helped us with that. And then we created a whole new validation via a gold standard, which had to be done by an expert from the Ministry of Health in Chile. So the main objective then was to identify facilitators and challenges for a further national expansion. This was a little bit of the planning, like looking at it in general from January 2025 with the project's kickoff, starting with the first meetings between the different stakeholders that were part of it, PAHO, the Ministry of Health, the Department of Health in Maule, the Curico Hospital, and yours truly, and my team, the lab team. So we conducted a series of introduction trainings to this team at the hospital, where we were going to apply the potentials of the ICD-11, how the browser worked, how it was coded. And this led us to the design and technical development in informatics, helping us have a setting that would be then to allow it to work for them in private, because the objective of this pilot was not only to test the usability and the further matching and the diagnosis of the hospital discharges between physicians and coders, but also to be able to have all this technological development that was inserted in the pilot to be easily exportable, replicable, put together in a package. In May, we started with the records and registrations for 1 or 2 months, creating the records. So in general, it was quite a heavy month. The rest of the time, it helped us to analyze what things needed to be further done. So it was to like assess the pilot in general, to be able to hand it over and then to be able to scale this pilot up into other initiatives. From the standpoint of the tools we used, as I was telling you, the first objective was to assess, because it was the first time that we were doing this deployment of the ICD-11. So we decided to work very rigorously in terms of the indications, because the idea was to replicate the whole guideline and the information that the Ministry of Health is providing to the actual machine, so that anybody who wanted to replicate the model, and there were some other papers that were helping us, some scientific papers with experiences like in Kuwait, Iran, China, that had previously done something similar as well. So we conducted literature assessments, and we started with the work. And the first thing was to able to integrate everything that was related to the Docker, which is the technical concept that is also included. And so the idea is that all of these API could be put together in a package and easily installed in various servers. And that installation at the same time could be done in one server or the other in the same way. And the most simple of commands to download an image, which was to download the full API from the actual side of the WHO, to create the containers, the license, the versions, and also to look at the various language, because it was important to deploy this pilot in a language that could be familiar to clinicians and all those that were going to use it, the settings, so that it could be an automated implementation. And we're going to tell you how we did it, to have a local configuration and another one as a backup. So if we had any issues in one of them, then the other one is activated to validate the local access to the coding tool. So this is a little bit of the look, the display of it. This is a bit technical, so I'm not going to delve so much into technical details, but if any of you wants to, you can send me an email. We can help you. We have the documentation for it. We have the WHO as well, with the guidelines and the application. But that's the moment when we pretty much like stick our flag on and say this is ours. Let's launch this API, and this is a little bit of the message that we convey when you launch that container, and then within the local environment, in this case, that image of a computer. When we were testing, we created the setting, we launched the API, and now we can see the coding tool. So this is to say that we have now a coding tool within our servers. This is a little bit like to position the architecture that we worked with. And here I'm going to use this pointer so that we can differentiate where is it that we are at. From the presentation layer, for instance, this is an architecture that is rather conventional, called MVC. MVC is an architecture that is understood in informatics. It's divided into 3 layers. And the C is called basically because of the model view controller, which means to simplify and contain each layer, as in a capsule, where we have a presentation layer that is closer to the user. This is what the actual user is going to look at. So this will be like the presentation layer, what the interface is going to look like for the users that have access to it. So where we have the users, mostly the administrators of the platform, the clinical users, and the coding user. They had to work together with us and feel comfortable with the pilot. So we needed to create an informatic pilot that could help us to work with the administrator, and that could also be easily used as an interface with the whole setting, with the whole environment. They wouldn't have to be constantly coding. The clinical user, of course, they had to do with the clinical records, and it needs to be interoperable with the API of the ICD-11 and the coder who will analyze this data. So we had to provide a support to this coder so that they could give us information from the variation code standpoint if they were applying or not. So all of this via a web interface that if we have time, I'll show you. And here we have the actual business layer where we are located. And so we have the business logics, which is where things actually happen, the validation of the diagnosis, the actual DAISY API, which is our platform, where we have it linked to the ICD-11. We have a statistics module and a security and safety module through a token to make sure that we could have users that were registered, authenticated correctly, and the information coming through the healthcare services servers to some that were regulated by ourselves. This is very important, and I say it because these are topics that in a way or another, when someone wants to try a whole new pilot, they need to consider all of this, because no one would like to have some kind of weakness, because in the end, they do have to face cybersecurity issues. So this is what it would allow us to include, for instance, the institutions, the specialties, so the configuration of the whole system. And then we have a coding engine. All of this is included and integrated with the persistence layer, which is where data is actually going to be stored. So this is the database itself. And we had separated these modules into those three layers, what the user see, the business layer when things happen, with the scripts, where the data is going to be analyzed, and the presentation layer, which, I'm sorry, the persistence layer, which is where information is going to be stored, relational databases. So the whole API is going to be there and it needs to be redundant, and it was redundant in the sense that we had a local API closer to the clinical to the electronic clinical records. And that was intentional because it needed to be the closest that could be either in another server, but hopefully within the same data center, or within the servers where the IT team of the Maulis healthcare service or all of that was a great input, which are the experts, interoperability, would help us and to bringing this API the closest possible to the electronic clinical records. And that is so that we could be able to prevent any latencies, because we could have some kind of latence or some kind of delay because the informatics web. So the idea is to have it closer. This API had an issue that it was constantly failing, the power shut-offs. There was constant issues. So we had a support for that, a backup, which was the global API inserted into the servers of the ministries of health. So they would constantly work together. And so we needed to look into the local API because of the closeness. And if it was not available, then we would look into the global API, which is the one inserted for the ICD-11 as well in the Ministry of Health. And we have a database to put together all this data that we brought from the data analysis, because we did have the local, but we needed to have it enriched into the healthcare service in a hospital. So here we had a persistence layer on this data where we then export data, the primary data, to the data persistence layer to be able to analyze them. From the process standpoint, the process that we had said and actually followed would start, previously to this configuration, we had set the application of the pilot. So we looked at the hospital discharge data and to enter it within two different clinical services, which are medicine and psychiatry, which I didn't mention. But it is important to mention that because it was not all specialties nor the whole hospital. We started with psychiatry and medicine itself. So the entering of the hospital discharge, which is what I was telling you, is bringing the API available, because this entering of the hospital discharge was something that was being done with the whole configuration that I showed you. It had to do, it would prompt the ICD-11 APIs, and so if the local one was not available, then it would reach out to the global one, which was the Ministry of Health, which pretty much mirrors the one that we had at the healthcare service in Mali. If it's available, then we would look into the API and show it to the browser, so that within that browser, the physician would look at what was the diagnosis as shown in the website, only with an emergent window that show the API. Then we select the diagnosis, save it, and if it wasn't complete, then it had a different pathway. And this was already in the electronic records. And if not, then it would request to fill it up, or is going to tell you that you needed some more information. And if it was complete, then you would export it. And then we would immediately come up to the baseline platform, which we incorporate the security mechanism so that we could have a as secure access. And then we would record directly all these codings in our platform for a further analysis. Because we would not intervene into the records in the electronic records, because that itself has a different way, a primary use of information. And that primary use of information is rather clinical. So since what we need is specifically the diagnosis itself, then what we did is we'd export these diagnoses, export the coding to our platform, to the platform we developed, so that we can conduct further analysis. So this is what it looks like. So this is what we were going to do. It simulates what we can see in the website. And here I have the actual, let me see if we can see it. This is the browser, this is a platform. And I have the access to administrators. So we incorporate, for instance, the ICD-10 to ICD-11 mapping, so we can also have a lot more information. All the diagnoses could also be mapped. And this was done mostly through the file that the WHO provides. They provide the mapping, we incorporate it in, and then it would be performed automatically. Okay, so there's the institution specialties that are included, obviously all of them, but as I was saying, it wasn't applied in all specialties. It was applied only for 2 specialties. Here we also have the training with the small interface of training. So the idea is that we could provide education to people. It allows us to create a registration, a record, and it has these code numbers that are related to the statistical record of hospital discharge used in Chile. Obviously, each number would have something to do with a specific reference, because not all fields were being used, because it wasn't the purpose of the pilot to actually create a symbol of the full statistical record of discharge. So we used some of the fields that were rather testing fields. And the most important part is below, where we have the actual diagnosis. And this is something that we import from the electronic clinical records. So this interface is like a training interface. It's a little bit to be able to train the actual objective audience that we needed to work with. So let's see an example here. I'm just giving you an example, diabetes mellitus. And here, this is what it's going to look like. Something's missing. It did not open. Okay, that's why I have it in the slide, because if the internet fails, I have. So I have to enter the main diagnosis, and then would go into the browser where would find the entity and select. And we could see directly what was that and leave it registered there. So here's a video I'm going to skip, because it's a little bit of what I had already been telling you live. Okay, so here we have the ICD-11 records. These are records, and this is part of the training. This is a platform to create a code, completely integrated with the API. But to analyze all the data that came from the pilot, what we did is we put it here. And so we have all diagnoses here. And they would go through further or validation filters as well.
La revisora inicial, que
We
es
had the
la
initial
registradora,
reviewer, which
codificadora
was
del hospital
Patricia
con mucha
Rojas, the
experiencia,
coder,
del
the
hospital
hospital with a
de San
lot of
Juan de Dios de
experience in
Curicó.
the San Juan de Dios de Curico
Y lo
Hospital.
que aquí tenemos, por ejemplo,
And here
una
we have,
lista de
for
cómo ellos
instance,
lo
a
veían. Aquí
list
están las
of how they would
instrucciones
see it.
porque era
These
bastante
are the
simple, ¿eh? Era
instructions
bastante
because it was
simple,
quite
consiste de
simple
un switch y el switch
from
uno
the
lo podía
standpoint
dejar
of just
en
clicking on a
correcto o
switch that
incorrecto,
you would
decimos
leave it
en Chile que
incorrect
lo
or
están cerrados.
incorrect.
Entonces uno podía mover el switch
So one
y
could
dejar
move that
el
switch
diagnóstico como incorrecto
to
o
leave
correcto.
that
Y después
diagnosis as
volvía a
right
ser
or wrong,
validado por
correct or incorrect, and it could be
la validadora
validated
gold
further
estándar del
by the
Ministerio de Salud.
standard
Y
validator
cada
from
una
the
obviamente
Ministry of
dejaba
Health.
su
And so
registro.
each of them
Entonces
would
aquí
leave
podemos
their
ver
own notes and
el
records.
registro de cada una y
So
algunas
I'm going to see
etiquetas
the
para
record
decir
of
el
each of
por
them and
qué
some
ella
labels
consideraba
to see
que
why is it
estaba
that she
incorrecto
thought that
ese
it was
diagnóstico.
incorrect to use that diagnosis.
Entonces, esta plataforma nos ayudó mucho.
So
Nos
this
ayudó
platform
mucho
helped us a lot,
principalmente en
mostly
el análisis posterior,
in
porque
the further analysis
la
because
data
data,
de registro la teníamos en los servidores
the
del
record
sistema de
data, we
salud,
had it
pero
at
nosotros
the
necesitábamos
healthcare
analizar
services, but we needed to
los registros,
analyze that
obviamente.
data.
Teníamos qué porcentaje de
And so we
concordancia
had to see
teníamos
what was
entre
the matching
médico,
percentage we
codificador
had
del
between
hospital y
physician
posteriormente
and coders
codificante.
at a
O sea,
hospital,
¿cómo había
and
sido ese
then
piloto?
what
¿Qué
would
números
that be
podíamos obtener?
matching with the
Del punto
gold
de vista del diseño
standard?
metodológico de
And so
aplicación
from the
de este piloto, bueno,
methodological
ahí está
standpoint
Curicó, para
of the
quien
application of
no
this pilot, we have
conoce,
Curico
este, bueno, un
Hospital. For
mapa de
those of
Chile,
you
y
that
este es la
don't know,
región
this is
Chile, este es
our
el Valle Central
the
de
map
Chile,
of Chile.
esta es la región del
In the
Maule,
Central
y esto
Valley,
acá es
we have the
Talca,
region of
y esto
Maule. I'm here in
está a
Talca.
60
Curico
kilómetros
is
hacia el
60
norte,
kilometers north
hacia
of
la capital
me,
Santiago,
and further
y
up
la
the
etapa,
capital,
lo que les
Santiago.
comentaba, de
And
planificación,
well, this is where the
capacitación del equipo
phases,
clínico, el
planning, the
desarrollo
training of the medical
principalmente de las
team, the
herramientas
development of the tools,
informáticas, la
the IT
codificación,
tools,
que fue
the
el piloto
coding
propiamente
itself,
tal, y
which
el
was the
análisis.
pilot itself, and
¿Ya?
then the analysis.
¿Cuáles fueron los servicios que
And these were the
intervenimos
services that
en el
we
año
were intervened
2025?
that we
Medicina
intervened
interna y
in
psiquiatría.
2025. We had internal
¿Ya?
medicine
Y
and
las herramientas
psychiatry,
utilizadas
and the
que
tools we
de alguna
used
forma yo las estaba
that in a way
desarrollando y
I was
estaba comentándoles.
developing them and
Daisy
telling you
es la
about
plataforma que nos
Daisy, which
sirvió
is
para
the
el
platform that helped
análisis
us
y es una plataforma
to
bastante
conduct the
adecuada de
analysis, and
formación,
it's quite rich
para
for
colegios médicos.
training,
Sí, porque como
for
está directamente
courses,
vinculada
because
con
it
la
is
API,
directly
no hay que hacer
related to the
absolutamente nada.
API.
O sea,
So you don't
simplemente
have to do
uno ingresa
anything, and
y ya
absolute.
empieza a
You just
codificar.
enter and start
Entonces es
coding.
bastante
So it's
rica
quite
para, y como
uh,
tiene estos perfiles de
quite rich,
revisores,
and since it has these
uno
profiles of
incluso
reviewers,
puede cambiar ese
one
perfil de
could even
revisor
change the
por un perfil de
profile of
profesor
reviewers
o
for a
perfil de
profile
tutor
of
para hacer una capacitación y
tutor or
posteriormente
professor
evaluar los
to make
diagnósticos que
a
hacen los
training and
alumnos,
to assess what are the
los alumnos
diagnosis,
entre comillas,
the
o los
diagnosis
formados.
done by the
¿Ya?
students
Em,
or the
la API
learners.
REST y el navegador,
API REST
¿ya?
and the
Para el
actual
análisis de
browser.
datos.
For data
Entonces,
analysis,
para el análisis de datos, lo que se hizo fue, los
what
métodos
we
para el
did
análisis de
was,
datos fue primero extraer la
first of all,
información
we
de
extracted
los
information
servidores del servicio de salud del
from
Maule
the healthcare
e
services of Mauli
incorporarlos dentro de la
databases and
plataforma
incorporating them
DES.
within the
Esta
DAISY platform.
extracción, si
This
bien lo hicimos
extraction, although we did
en archivos de formato JSON,
with
no
JSON
llegamos a
format
hacerlo porque no fue el
files,
objetivo del piloto,
we
no
weren't
llegamos a
able
estandarizarlo
to
en un
standardize it,
formato
which was, by the way,
sintáctico
not
como
even the
Python.
purpose of the
Lo
pilot.
que sí queremos
We
hacerlo
didn't bring it
ahora,
in a
o sea,
standard
nos
failure
hemos
form or
pensado
anything like
porque
that. We have
pasar de un
sort
formato
of
JSON
working with that because
que el
doing
Servicio de Salud nos
is,
exportó a través de un
a
API,
migration from a JSON
toda la
format
información a la plataforma
with
DAISY,
all the information brought into
era
the DAISY
comunicaciones de API.
platform
API del Servicio de Salud
becomes
y
a
la API
communication
de
between
DAISY.
APIs from
Y
the
necesito
healthcare
traer de
services
un
and the
archivo
DAISY
en formato
API.
JSON.
So
Sin embargo,
we had
pasar
to
del
bring it
formato
from a
JSON al
JSON form
Python
about changing from
hay un gap
the from that
muy
one
simple de hacer. Entonces lo queremos
tighter
hacer
is quite
para
difficult.
poder
There's a big gap in
estandarizar
there. So
y mostrar
there's a lot that
también de
needs
qué
to be done
forma
to
se puede
standardize it and to show
importar y exportar de forma
how
estándar
it
a través
can,
de otros
how
sistemas.
export and importing can be
Las
done
variables
through
principales
different
del
standards.
análisis fueron los diagnósticos
The
principales y
variables
secundarios y
were
las
the
causas externas.
main
¿Ya?
in secondary
Aquí estamos
diagnosis and external
evaluando el
causes, and here we're
hospitalarismo,
talking
digamos,
about hospital
y las
discharge. So
herramientas a
let's not forget
utilizar en
that
el
part.
análisis del
And the
dato,
tools to be
que
used
ahí
in data
obviamente
analysis,
nos ayudó mucho el equipo del TELS,
where we had a
y
lot of
gracias a
help
ellos hicimos un equipo bien
from the
heterogéneo,
teams,
donde
and we
teníamos
had a very
ingenieros, teníamos
heterogeneous group.
Fue bastante rico el equipo desde el punto de vista de la heterogeneidad de las profesiones
We
y
had
la
coders and physicians.
interdisciplinariedad.
It was a wide variety.
Pusimos
and the interoperability and everything we had. And we also had error labels, mostly between the doctors and encoders profiles and the gold standard. The most important results we obtained were we were able to analyze within the pilot 457 hospital discharges. These 457 had a distribution between 279 from internal medicine and 178 from psychiatry. From that hospital that we told you, the Curico, San Juan de Dios, the Curico. So it had to do with the diagnosis that was coded by the physician who was in charge of that discharge. And then to that same diagnosis, we had a review from the institutional coder, which is Patricia, I told you before. And we also have, after further review of that same diagnosis, something done by the national reference, done by Ms. Piedra from the Ministry of Health. Daily is part of the team. We have quite a big and consolidated team, I must say, to work with the implementation, where we were able to discuss these results, and I will be able to share them with you. They were public, so they are in the PAHO website. And we're in a process of publishing some of the findings that we have from that pilot. So we considered the main diagnosis, external cause, and up to 6 secondary diagnoses for each record. That's the kind of data that we were analyzing for each. Within the actual coverage of the diagnostic review, we have, as I said, the main diagnosis, external, and secondaries. They were revised almost in full. We almost didn't miss any information. That's what I mean to say. So we don't have that many data that was incomplete or not looked at. And it was, if it's not present here, because it was probably useless. So it was almost a full review of 100%. In the diagnosis matching, we have mostly the matching of the gold standard with the coders. As you can see, is quite high, so much in the main diagnosis as in the secondary diagnostics. Where we're not very successful was in the external cause, which was one of the things we needed to analyze mostly to be able to socialize this information. So there are several causes on why was this matching so low between external cause expressed by the physician and then the one validated by the coders. There were 33 main diagnoses, out of which 97% had to do with the lack of post-coordination, where the most percentages had to do with it. So what I was telling you about the richness of the main code, matching a code that could be added to the same coding. So what was being done was to add diagnosis. So of course, coders that have the most experience and already know the features of the ICD-11 would mention and pinpoint at that to need any post coordination. So it was showing as an error. So the field with the most errors labeled was 250. And so it has to do with the code not being correctly linked. So we're no semantic errors, but most about the recording. One of the things we analyzed then was the external cause, is one that we had left open for anybody to incorporate any external causes. And we didn't apply any kind of business logic that maybe one type of diagnosis could bring several external causes. So it was open. So that could have been one of the most important reasons why we found so many errors in the external cost. And the secondary diagnosis, there were almost no errors, only 5 minor errors, where the most lack of coordination among diagnosis had to do with post-coordination itself. The reasons for these results, well, the diagnosis validity, we had a high matching between physicians, coders, and the gold standard. And some of them, it even reached 100%. What showed us that the intuitive and the usable of this browser and the practice has to do with what we said. It can integrate it into a clinical flow without compromising its precision. We had here a coder that had no great experience. It had some failure probably in the beginning. There was no specific training, very close training out that. We had an open course anybody could partake from. But in general, though, there were no problems. And from the standpoint of the use and the good coding of the diagnosis through the ICD-11 browser that we implemented. The most important errors, and this may be something that we have to work further with and emphasize on the training, is to incorporate everything that has to do with post-coordination. So handing over this very valuable tool to be able to help with better diagnosis. The use of the API was quite straightforward. There weren't many problems, not even from the structure standpoint or infrastructure. The interoperability and digital support. Daisy was quite friendly. Coders were able to work nicely because Daisy was a work rather for coders. So we import the data from the healthcare services because physicians were working mostly with the whole registration. So we had to bring to the availability of these coders and import these data to them. And they would work without any problems with the platform. So we can harness at the most the semantic potential of the standard and the technical support as well. This guide us into creating a good tool for a national application so we can create a roadmap for the providing of these ICD-11 to them and the state of Chiloé, for instance, incorporating in the goals of health, where the idea is to be able to scale it up in years to come, creating a good institutional governance. So the idea is that this pilot may be able to grow in several places at the national territory and regional territory as well. And the idea is to export this experience to help neighboring countries with the support and the implementation or pilots to scale up this learning. The future work that we are looking to for 2026 mostly is to consolidate this pilot and now incorporating a maturity model for healthcare institutions so that they can assess what is their status and the identification of gaps, mostly conceptual and imperative that can be practical. Also help support our regional guidelines so that it can be easily applied. So that this kind of presentations that I am giving you right now are not so user dependent, but very autonomous, just as the PAHO website provides both the ICD-11 API and the application guidelines, and so that we can also provide implementation guidelines incorporating DAISY tools and alike that we are living as a public good to leave them incorporated within that environment and create an IA draft that could help it be implemented in the various healthcare services and hospitals to apply it with the consequence of a pilot and then a further scaling up. By September, we will have the documentation, both technical and scientific, so that this can generate knowledge, can give us more light toward where to go and advance into a successful implementation, both at a national as the international level of the ICD-11 standards. To conclude, and kind of wrapping up this webinar a bit, the high technical viability, as I told you, is quite straightforward to configure. So if you don't want to do the whole environment that I told you, it's also valid. You can incorporate tools from WHO, and you can incorporate the ICD-11's browser within your API to be able to look at that browser. So you can download it, you can configure it, and you can just do that. And then you can scale up little by little. And so the next phase could be to be able to compare or to simulate a clinical record. So incorporate, for instance, within a presentation environment of a medical record, and that incorporation as an API. And then you can continually grow in complexity until you reach an actual clinical environment, which is why we did this pilot. And the objective this year is to be able to scale that up, hopefully to go from the pilot to all specialties in the hospital there in Curicó. I'm very wishful to have more hospitals joining in to increase also the diagnosis matching. Although percentages of diagnostic matching was quite high, we have reached mostly 100%. The idea would be to improve this gold standard and to emphasize on the external costs, because it also demands a business logic that has to do with the diagnosis. We have to work with that one. The most important errors that were shown in our work have to do with that, with post coordination. The post coordination that was found by coders, obviously coders have a lot of experience and are trained in this standard. They know it very well. And another important conclusion is to develop a scaling up and training strategy. So what we did is we planned further and create a plan of what we were going to do from the IT standpoint, but not only from the IT standpoint, also the clinical standpoint. So we need to have a clear strategy on how to summon people, second, how to train them, and third, to give time to set a pilot to help people get used to an initial testing structure to be able to assess this and be able to use this API that it has very powerful features if we compare it with the one before. So it has quite solid baselines. What we did, though, did not demand a lot of effort, neither from the economical standpoint, nor the technical standpoint, or the infrastructure either. So among these aspects, this is paramount because an economic aspect to consider could delay implementations that, from the technical standpoint could be quite simple. There isn't quite an elevated complexity to be able to create this API. And then the infrastructure standpoint is also quite simple. What we do have to do is backups so that we don't have to have redundancies. Hopefully, to have one local and one of high performance that will be a global backup. And it's something that could also be adhered to the WHO, although it will be a lot more difficult because it implies to have control on what's being done. That's why the local one is the most important one, the primary one. And well, clinical teams were very encouraging about it. Service managers, clinical department directors, they would really give a lot of support from the standpoint of having a good coordination with the clinical team and being able to incorporate these diagnoses and this new coding. This is our references and the results that we extracted in the pilot. come a little bit inspired from this. We're in the process of writing another one, and we're going to publish everything that has to do with that environment so that you can have it available and download it easily. So this is the website where you can find the information of the ICD-11 we just mentioned. And before I finish, I want to thank the whole audience. I can notice that we have a lot of people joining us. I'm quite encouraged to help you if you have any questions, if anybody wants to say or wants to create some kind of pilot or just get to learn more about this, I'm more than open to the questions you may have and questions that may come up later on as you interact with this, because as you advance with it, you have a lot more questions. And then finally, I don't know if Katri is going to refer to these maybe.
Many thanks, Dr. Sergio. It was a very good presentation. I enjoyed it a lot. There were a lot of questions. We have 3 minutes, the time for the simultaneous translation. I have tried to answer as many questions I can in the chat. If there are more, please, I assume that they can send it to you, Sergio, directly, or they can send it to me. I can put my email address in the chat, and I can also try to answer in those. I just want, before we're closing, to say again, so much thank you, Sergio. And we will continue working together with the Ministry of Health in Chile and Sergio and with his team for the second phases of the implementation. As I was saying, this was the first proof of concept, and now the pilot will extend it the other departments in the hospital and the further in the Chile's health system. But I want to take an opportunity to also to say that our next webinar will be on the 9th of April. As part of the webinar series, it will be presented with the Dr. Javier Vargas from Peru and moderated our medical doctor from Chile, Dr. Chiaki Miki, and it will be on the foundations of best practices in the digital transformation of the CRVS. So for the further note, I think that we will thank you for the participation. We had a full attendance, 500 people, that maximum amount that we were able to have. But we will have the recordings in the PAHO TV, so you can disseminate the video for the further with your colleagues, or to listen to the recording again if you wish. Thank you so much, and have a rest of the week and the day. Goodbye.
Bye bye. Thank you.